The room is too bright for winter. White tile, glass-domed lamps, metal trays lined like soldiers. Ether hangs in the air, sweet and chemical, drifting over the face of a woman whose abdomen has already been painted with cold iodine. Anna Mercer hears things before she feels them. The low murmur of men, the clink of a retractor, the soft rhythm of her own breath under the mask. Then suddenly, she realizes the breath isn't deep. It isn't heavy. She is not gone. A weight presses into her belly. Not sharp at first. Pressure, tugging, the unmistakable sensation that hands are inside where no hands should ever be. She tries to move. Nothing. Tries to speak. Nothing. Only the eyes under the drape flicker. Above her, Dr. Edwin Harrow, Chief of Surgery at St. Bartholomew Memorial Hospital, Boston, 1920, says, "We're making good time." No one on that tiled floor will record what she felt. So here's the question. When surgery was racing ahead in 1920, how many awake patients did medicine decide not to see? To understand what happened to Anna, you have to understand the kind of year 1920 was for American hospitals. This was the era when surgery looked confident. Antiseptic technique had spread. Surgeons wore gowns and gloves. Operating theaters had windows and galleries. Hospitals like St. Bartholomew Memorial in Boston prided themselves on modern methods. On paper, it looked safe. But under that surface, anesthesia was still human. It was usually ether or chloroform, often given by the most available trained person, not always by a dedicated anesthesiologist, because anesthesiology was still finding its identity. In our case, it was Nurse Lillian Cole, an experienced OR nurse but not a physician, holding the mask, watching the patient's color, counting breaths. There were no electronic monitors, no capnography, no machine quietly telling the team, "She's too light." Depth of anesthesia was judged by pulse rate, breathing pattern, pupil reaction, and skin tone. A person with naturally shallow breathing or a nervous pulse could fool you. And there was another pressure. Hospitals wanted shorter surgeries. Surgeons like Dr. Harrow became famous for efficient abdominal operations. Faster surgery meant fewer infections, fewer complications, and more cases in a day. So every minute the patient was under ether was, to them, a risk. In that environment, the unspoken rule formed, once you open the abdomen, you finish, even if the anesthesia isn't perfect.
Anesthesia was sold to patients as a mercy. You'll go to sleep, they were told, and when you wake, the pain will be over. That was the bargain. For Anna Mercer, 32, worn down by months of pelvic pain, probably a fibroid, possibly adhesions, surgery was supposed to be a turning point. Her chart in the surgical ledger, February 1920, would have read something like, female, 32, chronic pelvic discomfort, indicated for exploratory corrective procedure. That ledger is important. It's the object this whole story keeps circling, because the ledger only knows what the hospital chose to remember. On the morning of her operation, Anna fasted. She signed consent, brief, general, nothing like a modern risk disclosure. She was wheeled into the theater. Nurse Cole placed the open-drop ether mask over her face, gauze laid over a metal frame wet with anesthetic. The smell was sharp, sickly sweet. Patients often coughed or struggled in the first seconds. If you don't push through that induction, if you don't keep them under long enough, they pass into a light plane of anesthesia, quiet, breathing, but not truly gone. Surgeons like Dr. Edwin Harrow trusted their teams. He scrubbed in another room, gloved, came to the field when he was told, "She's under." To him, the patient was ready because the room said she was ready. The hospital believed in this system. It believed in ether. It believed in its own progress. What it didn't always believe was the patient's later memory. This is the part of the story medicine used to call post-anesthetic dreaming. We would now call it something closer to interoperative awareness, the patient becoming conscious enough to perceive pain, pressure, or voices while being unable to move or speak. For Anna, it likely began with sound. Voices became clearer. The overhead lamp felt closer. She could smell the iodine on her own skin. Then the sensation, a pulling, a deep pressure below the navel. Not the sharp, clean pain of a cut. Ether blunts that first slice, but the raw internal discomfort of organs being handled. She tried to move her arms. They were restrained at her sides. She tried to speak. Her tongue felt heavy, her throat dry, her pulse probably quickened. This is where Nurse Lillian Cole might have noticed. A faster pulse, speeds of sweat, slight grimace under the drape. In a more cautious room, the nurse might have said, "Doctor, she's light, more ether." In a more modern room, the team might have paused. But it's 1920. The abdomen is already open. They have a limited sterile window, and Dr. Harrow is proud of finishing quickly. So a judgment is made. Continue. This is the ethical crack. Not a villain with a scalpel, but a culture that says the operation matters more than this woman's present suffering. When Anna later tells them, "I heard you, I felt it," the words won't match the ledger. And whenever that happens, institutions tend to trust the ledger.
Anna survives the surgery. That has to be said plainly. Her wound is closed, she's taken to recovery, her vital signs stabilize. A few hours later, still weak, still groggy, she says the kind of sentence hospitals don't like to hear. "I was awake." Maybe she says, "I heard you talking." Maybe, "I felt you inside." Maybe, "Why didn't you stop?" A nurse writes in small cursive, "PT reports vivid intra-op sensations." That line, or something like it, is found later by a junior doctor, Dr. Samuel Keene, who is curious about these anomalies. But the official chart doesn't change the diagnosis. The hospital decides to call it post-anesthetic delirium. That term is safe. It places the problem in the patient's mind, not in the hospital's methods. Why not admit it? Because a documented case of an awake patient during abdominal surgery would force the hospital to answer difficult questions. Was anesthesia administered by properly trained staff? Was the patient adequately induced before incision? Was speed prioritized over depth? Did anyone in the room ignore signs? Those questions lead to liability, to reputation, to donors, and St. Bartholomew Memorial is a respected institution. So instead, the truth is split. In the official surgical log, the operation is successful, uncomplicated. In Dr. Keene's private notebook, the other ledger in this story, a more human line appears. February 1920, female, 32, reported hearing surgeons feeling abdominal manipulation. No provision for patient account in formal record. Must investigate incidents. This is how a lot of medicine's quiet failures survived, not in the chart, but in the margins of somebody's notebook. And in the professional journals of the time, things like A Simulated American Journal of Surgery, Volume 34, 1920, Observations on Partial Anesthesia in Gynecological Cases. Awareness is mentioned only as a complication, not as a trauma. It is, in other words, recognized, but not fully believed. From where we stand now, this looks barbaric. How could they keep cutting if she might have been aware? But we have to remember what 1920 medicine knew and what it didn't know. They knew ether worked, most of the time. They knew longer surgeries meant more risk. They knew that pausing mid-procedure increased infection chances. They knew that patients sometimes said strange things after anesthesia. What they did not fully grasp was the psychological injury of being awake and paralyzed on the table. Pain was seen as a momentary cost, not as a lifelong memory. They thought, she lived, the surgery succeeded. Outcome over experience. That's the heart of forbidden medical history, the gap between clinical success and human cost. And the ledger keeps showing up. The official ledger says, successful abdominal operation, female, 32, uneventful. The private notebook says, patient states she was awake, distressed. Two histories, side by side. Modern anesthesia, with better agents, gas delivery systems, trained anesthesiologists, depth of anesthesia monitoring, grows partly out of these unrecorded grievances, out of people like Anna, out of all the patients who said, I heard you, and were told, no, you dreamed.
So what did this teach medicine about itself? That if a system only records what flatters it, it becomes capable of cruelty without noticing. That silence in the operating room does not mean silence in the memory. That a successful surgery is not always a merciful surgery.
We remember the dazzling surgeries, the first heart operations, the first separations, the first transplants. We put those in textbooks. We don't remember the woman in 1920 who lay on a bright table, heard men talking over her open body, and was told later it didn't happen. Institutions advance by forgetting certain stories, by calling them delirium, by writing no complications, by keeping the ledger clean. But medicine, if it wants to stay human, has to tell those stories too. Because a body on the table is not consent to suffering. And if you found this episode unsettling, the next one goes even deeper. A case where a children's ward was used to test an improved serum, and every bad outcome was filed away as unrelated. Same era, same belief, same quiet harm. 12-word moral rule. When relief is secondary, surgery becomes a quiet theater of harm unseen.